Thanks. So I'm back to try to convince you that we do have enough data to eliminate chemotherapy from initial CLL therapy at this point. So I thought I would start by reviewing very briefly where we are with chemotherapy, which we just saw, starting historically with single-agent chlorambucil, moving to purine nucleosides, and then purine nucleosides and alkylators. We saw improvements in response rates and progression-free survival, but no effect on overall survival. In the era of chemoimmunotherapy, we did have an effect on overall survival, but not with chemo, instead with antibody, rituximab. And so let's look at just how far that has gotten us, FCR in the CLL8 study, median PFS of 52 months in this analysis, which I'm using because it's more comparable to the other data I have to show you. But you'll notice that there's a continuous decline in the curve without a plateau, and that 3 years post-randomization, 65% of the FCR patients were progression-free. So 65% 3 years after randomization. And if we look at the incidence of refractory disease, the early progressors, we still have 30.9% of patients who progressed within 2 years of their FC or FCR regimen. So 31% early progressors. And we've heard at some length already about the various problems with chemotherapy. We just saw continuous relapse. We know that with each subsequent therapy, remission is less likely and shorter. Patients with 17p and complex cytogenetics respond poorly from the start. Elderly patients, who are most of them, tolerate chemo poorly, as we just heard, with risks of myelosuppression, immunosuppression. There's the increased risk of second malignancy in CLL, and the degree to which the chemotherapy contributes to that is not entirely clear, but we worry about it. And then we discussed this morning also the issue of clonal evolution, and how much does this selection for pre-existing adverse clones versus the possible induction of new clones by chemotherapy. So what are our alternatives? Well, we have reasonably mature data in previously untreated patients with or without rituximab for lenalidomide, idelalisib, and ibrutinib. And there's also evolving data with obinutuzumab, or GA101, a novel anti-CD20 antibody. So I'll talk about all of those. There's also a deep pipeline of novel agents in earlier phase development, and we've heard already today about IPI-145 and ABT-199, which are very promising, but I won't discuss them as we don't yet have upfront data. So what about lenalidomide? Well, as you know, it's an immunomodulatory agent that promotes CLL cell activation, but is not cytotoxic to CLL cells in vitro. It's also one of our few agents that helps the immune system. It promotes T cell function and can have restorative immune effects, as I'll show you. A number of studies have suggested it's effective in relapsed refractory CLL with response rates up to 35 to 50%, although it can be difficult to tolerate with tumor flare reactions that can be painful, tumor lysis, and myelosuppression. And it often may be better tolerated with antibody given first, as the MD Anderson has done. And the mechanism of action is still somewhat unclear despite extensive study. So these are the MD Anderson data for lenalidomide in the upfront therapy of elderly CLL patients with a median follow-up of 24 months. We have 88% overall survival and 60% progression-free survival. And now with longer 4-year follow-up, time to treatment failure has not been reached, overall survival 82%. And for responders, 58% had a duration of remission greater than 36 months, shown in the top curve, which looks quite impressive. Immune parameters, including T cell function and immunoglobulin levels, improved on lenalidomide. And Christine Chen did a similar upfront lenalidomide study. When the study was initially reported with 21-month follow-up, the partial response rate was 56%. Last year, it was reported with more extensive follow-up of 53 months, and response rates up to 72%, including 20% complete remissions, median duration of remission 40 months. And this reflects what we know about lenalidomide, that the median time to best response is prolonged, in this study, 18 months. And so the 3-year progression-free survival in this study for lenalidomide was 65%, which is what we saw for FCR in CLL8. 3-year overall survival, 85%. And there have been progressions in some second malignancies, but this is also not unexpected in any CLL study. So in summary on the status of lenalidomide, we do have mature data in previously untreated elderly patients that looks very promising. But earlier this year, a pivotal company-sponsored phase 3 study of lenalidomide versus chlorambucil was closed early due to an excess of deaths on the lenalidomide arm in patients over 80. Plus, there were significant dropouts early on that arm in this study. And so we will need to see the full data from that study, which I believe will be presented at ASH, to know exactly where this agent stands for broader use at present. So now I'll turn my attention to the kinases in the B-cell receptor pathway, which we've, of course, already heard quite a lot about. And I'll focus predominantly on idelalisib and ibrutinib. So as we've heard, idelalisib is a highly selective inhibitor of the PI3 kinase delta isoform with an EC50 of 8 nanomolar and less than a 10-fold shift in EC50 in whole blood. I'm going to discuss the data presented by Susan O'Brien at ASCO this year of a phase 2 single-arm study done in elderly patients who were treatment naive. Idelalisib was studied at the recommended phase 2 dose of 150 milligrams BID in combination with weekly rituximab for 8 doses. Idelalisib could continue indefinitely as long as patients were receiving benefit. The baseline characteristics are shown here. 64 patients were enrolled on the study with a median age of 71. 42% had advanced rise stage disease. 41% had B symptoms. 58% were unmutated IGHV, and 14% had 17p or p53 mutation. These waterfall plots show the nodal response at 8 weeks as well as best nodal response, and you can see that almost all patients had a nodal response. There are a significant number of not evaluable patients, mostly due to patients lacking adenopathy at baseline. The overall response was 97% with 19% complete responses. And as you saw earlier and is also here, this response rate was preserved in the high-risk 17p and p53 mutant patients. And in fact, there have been no on-study progressions in 24-month follow-up. And that compares to what I told you for the 30% progression on FCR in the first 2 years. This shows also the improvement in cytopenias, which are seen in patients cytopenic at baseline. Now, this slide summarizes the adverse events on this study. And there are a number of significant adverse events. Diarrhea is perhaps the most significant one, with the 23% incidence of grade 3 or greater diarrhea, including colitis. And this tends to be a later event occurring at 9 months and is immunologically mediated, somewhat like inflammatory bowel disease. It seems to be more common in the untreated patients than in the relapse setting. 17% of patients had pneumonia, and transaminitis also seems to be somewhat more common in the upfront CLL population than in the relapse population, with a 23% grade 3 incidence. That being said, if one is prepared for these toxicities, they can all be managed effectively. And certainly we're used to managing these and worse toxicities with chemotherapy. And so this is the progression-free survival, 93% at 24 months. And again, if we're thinking about FCR, we had 65% at 36 months, but 31% of relapsers early in 2 years. Now, I'll grant you this is a phase 2 study, and that's a large randomized trial, but this is still pretty impressive data. So ibrutinib, we've also heard about, covalent inhibitor of BTK, IC50 0.5 nanomolar. Here, I'm going to discuss the data from the treatment-naive population, which Rick Furman presented at IWCLL. There were 31 patients, most of whom received the 420 milligram per day dose, only 4 of whom received the 840 milligram per day. The patient characteristics, again, a median age of 71. 48% had rise stage 3-4 disease at baseline, 55% unmutated, and a lower frequency of 17p deletion, only 7% amongst these patients. The median time on treatment was 21 months, and there are 5 patients who have discontinued, only 1 for disease progression, which is the Richter's transformation case we heard about earlier. A couple of adverse events mostly felt to be unrelated. This shows the common adverse events for ibrutinib, and you see diarrhea is at the top of that list as well, although this is a somewhat different diarrhea, usually earlier and usually more likely to be self-limited. And then we see nausea, fatigue, and contusion or ecchymosis, which is part of the possible issue of the effect on platelet function of ibrutinib, which is not proved to be a significant clinical problem by and large. This illustrates the safety in terms of hematologic toxicity. You can see is almost non-existent in the treatment-naive population, and even grade 3 infections only about 10% in the treatment-naive population. The drug's very well tolerated. Response data you've already seen, 71%, 13% complete remissions for this very well tolerated single agent, and an additional 13% of partial response with lymphocytosis, where the lymphocytosis is not quite resolved. So we're really in the mid-80s% for responders. No effect of bulky disease or 17p deletion on the high quality of response. Immunoglobulin levels are stable, or in the case of IgA, even improved on this agent. And here we see the progression-free survival curve. Again, looking essentially flat, 96% at 2-year follow-up. So in summary, we have mature follow-up data with lenalidomide, idelalisib, rituximab, and ibrutinib, which demonstrate what appear to be at least comparable and what may be possibly improved progression-free survival compared to chemoimmunotherapy. Oral agents are preferred by patients and toxicities are manageable. And can we improve even further on these outcomes? So I wanted to say a word about GA101, a new anti-CD20 antibody. It's a type 2 antibody. It has enhanced ADCC through glycoengineering, and it also mediates increased direct cell death, not through apoptosis, but through a lysosomal mechanism. And it's been studied in previously untreated CLL patients with comorbidities in the German CLL 11 study, which randomized patients 1:2:2 to chlorambucil, GA101 plus chlorambucil, or rituximab plus chlorambucil. The stage 1 data were presented at ASCO by Valentin Goethe, and those are just the antibody chlorambucil versus chlorambucil alone. The stage 2 data directly comparing the antibody arms will be presented at ASH. The patients had median ages of 72 to 74. They did have high Sears scores above 6, indicating some level of comorbidity in 3/4 of the patients. Creatinine clearance was still reasonably decent. And these are the response rates. So either antibody, GA101 or rituximab, both doubled the response rate. But I think what's notable here for the GA101 arm is that there's a 22% complete response rate, essentially due to the GA101, since there are no complete responses in chlorambucil, and 31% incidence of MRD negativity in peripheral blood. Again, rather unexpected for upfront antibody. You can see even with the rituximab arm, although that's not a direct comparison. So I think this is encouraging for the potency of GA101. These are the progression-free survival curves as they stand at the moment. The curve is still quite immature for GA101 chlorambucil and will be updated at ASH. So in summary, kinase inhibitors and IMiDs, plus minus anti-CD20 antibody, possibly with the promise of GA101 as well, show durable remissions in these previously untreated patients. These have led to the initiation of randomized comparisons with chemoimmunotherapy. In the US intergroup, there's an ECOG-led study of FCR versus ibrutinib in those under 70, and an alliance-led intergroup study of bendamustine rituximab versus ibrutinib rituximab versus ibrutinib for those over 65. Idelalisib studies are being initiated, and it's likely that IPI-145 and ABT-199 are also going to move into the upfront setting. And so I think this is very exciting in terms of what it means for upfront therapy in CLL, but there are many questions that remain for us. Some include, how do we best combine these agents with each other or with antibodies? Is rapid remission induction important? And I think it might be, as we discussed earlier, related to subclones. How durable are the remissions in 17p patients? How do we best sequence the novel agents? Are more relapses occurring as Richters, as we discussed earlier? What are the long-term side effects of these agents? And where then do stem cell transplant and CAR T-cell therapy fit in? And so it's very exciting times, even with all these questions remaining to be answered. But I think we can look to the 2010s as the era of the novel targeted therapies, BCR and BCL2 antagonists, IMiDs, maybe other categories as well, plus monoclonal antibodies. Thank you.